Now we will discuss tiered approaches to intervention within the scope of trauma-informed care. So by the end of this module, our goal is that you will understand the tiered approach to providing trauma-informed care, identify how it aligns with the multi-tier system of supports, and lastly, be confident in providing examples of school-based therapy at each tier intervention. This is a visual of a three-tier model that is considered best practice for trauma-informed care. It comes from the public health field and it can be applied to many settings. In this hierarchical approach, Tier 1 includes providing universal prevention of trauma and/or chronic stress among groups of all people. As we move up the pyramid, intervention becomes more targeted and intensive, with Tier 2 targeting at-risk groups and provides support for people at risk for experiencing trauma and developing mental, emotional, and behavioral difficulties as a result. Tier 3 includes intensive intervention directly to those impacted by trauma and/or chronic stress.
That tiered model may remind you of the tiered model of multi-tier system of support, or MTSS, that's commonly implemented in schools. Within MTSS, in the academic realm, it includes Tier 1 support, such as providing high-quality curriculum standards for all students, Tier 2 level support, such as small groups for students who require additional instruction, and intensive academic support for students at the Tier 3 level. Within the realm of behavior, MTSS includes positive behavior supports at Tier 1, group skill interventions such as social skill groups at Tier 2, and customized interventions at Tier 3. MTSS can target a variety of student needs, which can include a broad implementation of trauma-informed practices and increasing support for all school staff. For optimal outcomes, research suggests that trauma-informed care in schools should be outlined within a specific evidence-based multi-tier framework like that of MTSS. This requires strategic planning to ensure accuracy, scalability, and durability of programs for long-term implementation. And while whole school MTSS programs include school therapists, the role of those therapists in programs such as MTSS has not yet been specifically evaluated in research. However, research does suggest that school-based therapists can effectively practice trauma-informed care with students at each tier of implementation. We now want to provide some examples of trauma-informed care that can be implemented by school-based therapists at each tier. When using Tier 1 level trauma-informed care in schools, it's important that therapists adopt a universal trauma-informed care lens when working with all students, because we do not necessarily know which students may have a trauma history, and we also don't know when ACEs may occur in someone's life. This also applies to working with families, which we will discuss more in Module 6. Additionally, when providing universal trauma-informed care as school-based therapists, you can adopt a trauma-informed universal precautions, which should include best practices such as optimizing client control, creating a safe environment for all students, adopting a client-centered approach, asking students consent before touching them during your sessions, being mindful of common trauma triggers, and promoting positive and stable relationships. When providing Tier 2 targeted supports in schools, it's important to acknowledge that for some groups, chronic stress is more ubiquitous, such as those who experience racism, bullying, food scarcity, foster care, homelessness, caregiver incarceration, and more. Due to prolonged chronic stress that people in these groups experience, these students may be more at risk for developing behavioral, emotional, or mental challenges. As school-based therapists, you can provide extra support for at-risk students by providing individual or group interventions for those at risk, such as promoting healthy coping skills for reducing behavioral challenges, And you can also advocate for these groups and promote trauma-informed care within the whole school system. In their 2017 article, Basuk and colleagues published an article about adopting a trauma-informed approach when working with historically underserved populations. Within this article, they provided these guidelines for implementing Tier 2 level trauma-informed care in allied healthcare fields. And this includes establishing a person-centered standard of care, establishing collaborative healing relationships, upholding SAMHSA's 6 trauma-informed care principles as a foundation, as we described in Module 3, respecting all forms of diversity, understanding the effects of trauma, mental health, and substance use conditions, promoting the belief that recovery is possible for all, ensuring person-centered care is individualized and transparent, being accountable, and forming collaborative interdisciplinary teams. School-based therapy at the Tier 3 level is focused on providing skilled therapy for students with a trauma history. These can target behavioral, mental, emotional, or physical manifestations of trauma and/or chronic stress to improve function, health, and overall well-being. We will provide more specific examples of these in Module 5. When providing intervention at this level, you will likely need to also support and educate other school staff about focusing on the child's strengths, building resilience, and promoting safety and control for the student. You should continue to advocate for trauma-informed care within the school system because teachers, administrators, and other school staff may not have had training on this topic and they may look to you for guidance. It's also important to note here that it may be necessary to refer the child to other disciplines, such as psychology, if more advanced trauma and trauma-specific care is needed. We wanted to discuss some concrete examples of Tier 3 trauma-informed care from the research literature. Fraser and colleagues in 2019 published a qualitative study where they conducted semi-structured interviews with therapists who had specific experience providing therapy to children and adolescents with complex trauma. When asked to describe the challenges they saw in their clients, many of them noted trauma-related hyperarousal, which results from prolonged stress responses by the hypothalamic pituitary adrenal axis, as we discussed in Module 2. And this often prevents children from self-regulating, diminishes their executive function abilities, and strengthens maladaptive emotional responses. These children can appear as hypervigilant or they may look as if they're always on guard. In the article, therapists describe some of the most common functional concerns for children and adolescents with a complex trauma history that they saw in their practice. These included functional concerns such as decreased self-regulation and self-soothing, disengagement, decreased attention, challenges with planning, organization, and transitions, difficulty with activities of daily living such as bathing, toileting, etc., insecure or avoidant attachment styles in social participation, and difficulty reading social cues. These are all potential intervention targets that school-based therapists can address when delivering Tier 3 services to children with complex trauma histories.
We thought that it would be useful to discuss an example of the tiered approach of trauma-informed care that has already been implemented in a school setting. Dorado and colleagues implemented the University of California, San Francisco's Health, Environments, and Response to Trauma in Schools, abbreviated as HEARTS, program as a multi-tiered whole school intervention with 1,243 students from 4 different elementary schools. Tier 1 involved school-wide changes in the learning environments to promote safe, supportive, and trauma-informed practices. At the universal level, all students received training on coping with stress. School staff participated in training on trauma-sensitive practice, social emotional learning curricula, and addressing stress and secondary trauma. and caregivers were offered skill building workshops on coping with stress. Tier 2 involved psychoeducational skill building interventions for at-risk students, wellness support for school staff, coordinated care team meetings to address the needs of at-risk students, and district-wide efforts to revise discipline policies. And lastly, Tier 3 involved providing school-based trauma-specific individual, group, and family services to students with trauma-related mental health difficulties, crisis support for school staff, and district-wide improvements of the educationally related mental health services process. Results of the program evaluations show significant increases in staff understanding of trauma and trauma-informed practices, as a significant decrease in disciplinary office referrals, improvements in student learning and school attendance, and an overall decrease in trauma-related symptoms who received HEARTS therapy. We hope that providing more information about the tiered approach to trauma-informed care will help you think about how you can provide different levels of trauma-informed care to students that you serve. So in this module, we covered the tiered approaches to intervention, and in module 5, the next module, we will cover strategies with students.